Dr. Khan, thank you for joining us.
Thank you. Thank you for having me.
Pakistan recently recorded a large drop in infections. Can you bring us up to date on the situation today compared maybe to a few months ago, and what are the main trends?
So, I mean, the trend, as you well know, it started hitting us in earnest somewhere around last half of March, and then we peaked about a month later or so, hitting about 5,000 or so new cases, a little more than 5,000 or so new cases a day. Yesterday, we were down to 539. That's been a fairly steady trend. So we seem to be coming down rather well. A lot of it has been, there's a lot of speculation about why that's happening. And I guess it's many reasons, but some things were done well. Some things, of course, could have been done a little better. And I guess we'll be talking a bit more about those. But largely, the trends have been positive. There's been some speculation about false numbers. I suspect that's probably not true. From all I'm seeing, and we're looking at a whole number of sources of information, just not testing numbers. It all seems consistent. I mean, the numbers are already going down.
Tell us of the main strategies Pakistan is using to manage the virus and what changes, including the greater involvement of the military, have occurred.
So, I mean, the largest strategy was to actually very quickly in March, they constituted this central committee, which brought in a various number of sources of the response. So there were people who were testing on the ground, people who were going out and finding cases. There were people who were receiving information from hospitals. But the backbone of it all was a data compilation unit put together by an initiative by the government at the time called the Digital Pakistan Foundation. And they brought it all together. You can see that on the website that's out there called covid.gov.pk. They update it every day and has a number of graphs that are based on data. Well, on the back end of it, there were initially data coming in from about 450 to 500 hospitals and laboratories, the big ones. But now that's actually gone up, I understand, to something like 5,000 hospitals or so. So data are coming in. There were measures actually taken to encourage people, not force people to share their data. So that went rather well. People did and have been sharing their data. So that went well. Then the situation is discussed daily in the Prime Minister's office. It's presided over by the Senior Minister of Planning, and is also attended by the advisor for COVID to the Prime Minister. And these are smart people. Then the military, of course, sat in, and they were doing a lot of the implementation, the lockdowns and stuff that did happen. That was supported by the military personnel going out and making it happen. Military was also there in the coordination committee where they were actually helping do some of the analysis once they were guided by the epidemiologists. So it was a very well orchestrated and continues to be a very well orchestrated plan. The initial glitches that came was, as you know, Pakistan is actually not a top-down country. Provinces have a lot of leeway, particularly in health. They can do what they want. It took some doing to bring them all to the table, but that happened fairly quickly once everybody saw that it's to their benefit to share their data, because the feedback coming back from the center was actually rather high quality, and once they followed, they saw good results. The provinces, particularly Sindh, came along on board very quickly. So did Punjab and Balochistan and then Khyber Pakhtunkhwa, the KP province. the good part about having the diversity of responses from province was there were some ideas that were happening, and you could actually see the different effects. So, for example, Punjab initially wanted to have a very stringent lockdown and testing strategy. And they were warned that if they go this hard, people will shy away. And they saw that effect. And because the data were available in real time, they could actually see the adverse effects of their stringency within 2 to 3 days. And they backed off. That was pretty commendable that they could actually learn that quickly and respond. Over time, some of the things that have been improving is because they can actually geolocate cases, they were able to actually identify sectors within cities where large numbers of infections had popped up, and were able to clamp down, and that's what they call their smart lockdown. It wasn't citywide, it was sector, sometimes a few streets, sometimes a little larger than a few streets wide. That was done well, and the lockdown parts were what the army supported.
Interesting, one of your neighbours, India, they've had a terrible, we would say, trot over the last week, 2 weeks. Numbers have been increasing. Is there a problem, do you think, the lack of being able to track and trace just the general population?
Yes and no. So I think one of the big things, and that stands us apart from India, is India is much larger. I mean, they're about 10 times, 5 times as big as we are. They do have quite a few more population centers than we do. And we're really talking, this is an infectious disease that goes from person to person. It's expected to be more prevalent in large cities where people are densely populated close to each other. India has 4 or 5 cities that are bigger than Karachi itself, which is our largest city of over 20 million people. And then there's urban dense areas in India, such as in Mumbai and in Kolkata, that have population densities of over 1 million people per kilometer. That's a lot of people together. So if you get an infection in there, in one apartment building, I mean, as they saw, particularly in Mumbai, the entire building came down very quickly with the infection. We don't have, even our densest population centers in Karachi are not as high as that. I mean, you're talking 2-3 story buildings at most. There's just not the kind of density that India has. So that probably contributed to the testing part. I mean, I don't know about India per se, how they were doing or not doing, but in Pakistan, the thing was that a lot of testing was coming from people who had come forth to be tested because they had felt sick. Some of their contacts were traced. I think at some point we were thinking about 20% of all contacts were traced. But our tests were among the contacts. So testing was mainly done for patients, but seems to have sufficed because if large number of patients were coming in, that was considered a marker for a large group of infections in an area, and that area was important.
Australia's had problems, Australia, US, many Western countries, in fact, have had problems with tracking and tracing. They've not relied on surveillance tools like some successful Asian countries. What's the situation throughout Pakistan?
Something in between, I think. So we've not certainly been like China has been able to do, and maybe Taiwan and Singapore. But a lot of our tracking and testing has been voluntary. What has helped is there's a very good infrastructure of doing just that because of polio. So there's an infrastructure of personnel who have the ability to locate households and and so on and so forth, and find cases in communities and do it very, very rapidly within a day or two, and then a system that can collate all of that information, bring it into a centralized database and put it on a geographic map. So all of that has happened. Now, how well, I suspect it's worked better than it has not. And there's obviously been gaps people will identify to you if you talk to various public health specialists. But for large part, they've been able to do the bulk of the work that needed to be done.
What's the biggest challenge in managing the virus in Pakistan?
I mean, one of the big gaps that we felt has been communication. So people have been getting mixed messages, both from the federal and the provincial governments. I mean, sometimes you say it's not a big deal to start with. We don't want to do lockdowns, which is justified. But you can't. There's a way of communicating that. You can't just say we're not going to do lockdown because it stops economic activity. Of course, that's true, but there's something more to be said about, if the infection goes as it has in parts of Europe and now it's happening in the US. I mean, there's a problem with that. People need to be brought into confidence. They need to be told it's a problem. It's a big problem. But we can control it, and this is how we go about doing it. I somehow felt that we really didn't do that much with the communication. I think that's been a problem because people don't trust them. I mean, one day you're saying it's a problem, we need to clamp down, and then you're closing off entire cities, and 2 days later you say it's really not a problem and everything is fair game. An average person says, hey, wait a minute, you're talking both sides of the mouth.
Governments are really good, aren't they, at scaring people. It's pretty hard to unscare someone. So they do the job well at the start. They scare the bejeebers out of all of us. And then, as you said, next day, oh, it's okay. Go out and shop, enjoy yourself, wear a mask and good luck. So they're very good at scaring people. Look, the economic restrictions are in place, including border controls. What are they?
So border controls are now easing. The flights are starting to come in. I think they may not be completely up to the normal, but I suspect at least 50 to 70% of incoming flights are coming compared to the pre-COVID levels. Economic restrictions really aren't there anymore. As of yesterday, we pretty much lifted off virtually every restriction. Restaurants are open. Malls and shops have been opened completely. The only thing remaining, I think, are schools that are supposed to open on 15th of September, but everything else is pretty much on the go.
What about face masks? Is that mandatory? So far, all the experts that we've spoken to from South Korea, from Taiwan, have said that they are imperative, but for them to work, everybody needs to wear them.
Right, so face masks really aren't being enforced. So I think the current guidance is encouraged, as you said. But what's really happening is pretty much most people have given up. If you go to cities, there are basically two types of people. Extremely well-off people are self-distancing. Some people are still in quarantine full length. Those are very rich people. And then everybody else in the community, on the street, I mean, you hardly see very many masks outside the rich areas.
How long do you think this dreadful COVID will be around?
I mean, a lot of it depends on the countries. I mean, so the fact that the experts really haven't figured out exactly what's worked. So we know kind of, as you said, wearing masks, distancing work. So, but a lot of countries didn't do it. I mean, just step back a little bit. One of the things that we've been following is Google does a really nice mobility thing. You can look it up on Google Mobility. But what it does is it tells you how much people restricted themselves, or countries did that. And they did it at a country level and sometimes at sub-country, city and sub-city level for US and Europe. And so you saw that some of it matched the epidemic curve, but a lot of it didn't. So that was that. The fact that the epidemic was much worse in rich countries than in poor countries. Remember, as of the end of May, 96% of the deaths had happened in a rich country. Tells you something about population density. People had all kinds of theories. Herd immunity was one of them. People had the BCG theory. I think that kind of ties in with another theory that we've heard discussed. And I think all of these things actually have merit about that people here in South Asia and in rest of Asia in poorer countries are exposed to so many viruses and germs that we have generally higher immune responses. Maybe that's true, but all of these theories are yet to be borne out by science. But I think all of that is true. I think one of the big things has been that rich countries have denser networks of people, and networks have been a big reason why there's been such a difference between rich and poor countries. I mean, you don't come in contact with everybody all the time. You come in contact with something like 20, 30, 40, 50 people at most on a routine basis. Infection comes into your network, it's there. If your network isn't very large and overlapping, then infection stops within your network. You're not infecting the next person. I think that's been a big role in places like Pakistan, and I think in many of the developing countries. That said, I suspect there's going to be two epidemics. One is going to be in poorer countries like us, where it's going to be somewhat more limited. There's going to be a bigger epidemic in richer countries, and particularly countries like the US, which seems to sometimes not follow even the basically available information, as we're seeing right now, the rising cases in the face of people saying, hey, wait a minute, we don't really want to do the distancing and the masks and stuff. I mean, masks and distancing probably all help. None of them is the golden bullet. But you know, it's one of those complex things where a little bit of this and a little bit of that comes together. So I suspect that better messaging, a little bit better controls will help in most of the world. It will probably go on well into the 2021, I think. Beyond that, I mean, it's hard to imagine why an epidemic would sustain that long unless it becomes a new infection. The virus mutates into a new infection like it does with influenza and comes back with a new cycle. Right now, I don't think we know enough to say that will or will not happen. My guess is probably not. But yeah, I mean, we're in for 21 at least.
Interesting times, frightening on one hand, and on the other hand, a lot of hope, because we are how we're adjusting. And one scientist said we're learning to take a look at humanity and just look at ourselves. So I suppose another scientist said, out of every calamity comes opportunity. So we're all hoping and praying. Dr. Adnan Khan, thank you very much for your time today.
My pleasure, and thank you for having me here.